Hi, everyone, and welcome to today's Youngtimers Ask the Expert session. Today, we'll be talking to Dr. Laxmi Kondapalli about gamete cryopreservation, or in layman's terms, egg freezing and sperm freezing. Dr. Laxmi Kondapalli is a reproductive endocrinologist. She's board certified in obstetrics and gynecology and the subspecialty reproductive endocrinology and infertility. And she currently works at the Colorado Center for Reproductive Medicine and Fertility in Colorado. Her research interests center on fertility preservation, ovarian response to medical therapies, and assisted reproduction outcomes. Dr. Kondapalli, thank you so much for joining us.
Well, thank you, Lindsay, for inviting me to participate in this really important conversation. So I'm thrilled to be here this afternoon.
We're so excited to have you. I know that a lot of your research has focused on fertility preservation for oncology patients or cancer patients, but I really think that our rare disease community has a lot to learn from your field, and we're just so excited to have you and glean some insight and information on your expertise on these fertility-related concerns that I think face our community as well. So.
Absolutely. Well, I'm so excited to share the information that I have, and hopefully your audience will gain some insights and just be aware that these options are available. Even though I focus on fertility preservation primarily in cancer patients, I also take care of patients that have a whole host of medical conditions outside of cancer, where their fertility may be impaired or their opportunity to start a family may need to be postponed because certain types of treatments. So I think that my experience is very applicable to the Youngtimers group. So thank you again for inviting me.
Oh, very relevant. Thank you so much. All right, we have a lot of questions because our community has a lot of information that they're interested in learning about. So let's just get started. So just to set the groundwork, I was wondering if you could just define for us what is gamete cryopreservation or egg or sperm freezing.
Awesome. So a gamete is just the reproductive tissue that men and women have. So for women, our oocytes or eggs are what we can cryopreserve or preserve for future use. For men, the primary reproductive tissue is going to be the sperm. And so when we think about fertility preservation, there's a couple of different options that I have. For men, it's going to be sperm freezing. And for women, it's either freezing unfertilized eggs by themselves. So that's a great technique that's available. It is now standard of care. So a few years back, it was considered experimental, but the techniques for freezing eggs has evolved over the past 10 to 15 years. And so it's no longer considered experimental or investigational. It's actually standard of care. For some patients, they may go ahead and cryopreserve embryos. So you can actually take the eggs, fertilize with sperm, create an embryo, and then that fertilized embryo can be frozen as well for future use.
Okay, thank you for clarifying that difference between gamete and embryo cryopreservation, because I think some people get confused. And we'll get into a little bit more about that in just a minute. But before we move on, I just wanted to say that frozen eggs and frozen sperm must eventually be used in other procedures, such as in vitro fertilization to produce an embryo and then eventually a baby. And that IVF and the pre-implantation genetic testing process that can be done on embryos from people who may be at risk for certain genetic disorders, that we'll be discussing all of that in another video in detail. So if they're interested in that, tune in later. For right now, we're just focusing on, gamete cryopreservation, a little bit about sperm, but mostly about eggs, because it is such a thorough protocol. I think it's nice to walk women through what they can expect before thinking about doing that. So in your experience, what are the typical reasons that you see individuals pursue egg or sperm freezing?
Well, I think that I see a variety of different patients that want to come in for a consultation regarding fertility preservation. So certainly if I have patients that have a medical condition that may predispose them to issues in the future, they may want to seek a consultation with me and think about preserving eggs or sperm before they go through their treatment. And maybe if they face infertility, we have a backup option because we've been able to freeze the sperm and eggs, and they can continue and have a biological child in the future. So a big group of patients that come to see me are patients either with cancer, medical conditions, or even patients, there are certain types of blood disorders in which sometimes patients need treatment to kind of treat their blood disorder, and that treatment predisposes to long-term infertility. So they would come to see me to preserve eggs or sperm. We also see patients who specifically have a gene mutation that can be passed on in their family. And so they know that something like in vitro fertilization with genetic screening of embryos may be on their horizon in the future, but they also recognize that age is catching up to them. And we will talk a little bit later about how age has an impact on the health of our eggs and sperm. And so they may decide to come in and go ahead and freeze eggs or sperm when they're much younger, so that they can use it for assisted reproductive technologies in the future. And then I also see a lot of professional people. Perhaps men and women are wishing to hold off on starting a family until they're older in life. And we do know that the age of pregnancy and when women are starting a family is getting older and older. And because of that aging process, I do see professional women, for example, who will come to see me in their late 20s or early 30s to preserve eggs so that they can hold off on starting a family in the future. But those would be the primary reasons that a patient may want to have a consultation with me to talk about fertility preservation.
Yeah. So I know that, in the reason for pursuing egg freezing, and you touched on this briefly, in the general population, for example, they have low fertility or maybe low ovarian reserve, versus in a rare, genetic or even just disease population, would be very different. And so
Yeah.
I think, those two groups have very different, considerations to make when thinking about whether, they want to pursue that, taking into, their age, as you mentioned, their ovarian reserve. So what important considerations would you recommend for individuals in a disease group, to consider, before pursuing egg freezing? What are important factors that they should be thinking about?
Yeah, I mean, I think one of the biggest factors that is associated with the success of either freezing eggs or sperm is age, and that's particularly true for women. What's interesting about male fertility or male reproduction and female reproduction is that for women are born with a certain number of eggs, and that number is finite. So all women are pretty much born with the same number of eggs, but we lose eggs over our lifetime. The rate at which women lose eggs is different from woman to woman. So even though we all start off with the same number, we might be losing eggs at a faster rate or a slower rate. And age is the biggest factor that's associated with that egg loss. The other thing to keep in mind is that the older we get, the quality or the health of the eggs also declines, which means that the eggs that we have in our mid to late 30s may not be as healthy, meaning likely to result in healthy children, healthy embryos, as when we were in our 20s. So I think age is one of the biggest factors that's associated with a disease population or medical condition population that's important. For men, we also see that men's age also has impact on the quality of their sperm. So men who are in their 40s and above, their sperm can be more prone to having genetic factors or chromosomal errors that can result in embryos that are not healthy. But certainly for women, it's much more of an impact. For boys, boys are not making sperm until they go through puberty, and men can make sperm well into their 70s or 80s because there are stem cells within the testicle that can constantly reproduce sperm. Unfortunately for women, there's no stem cells within the ovary, so we are born with all the eggs that we'll ever have, and then we lose them. over a lifetime. So that time factor is going to be different from a male patient versus a female patient. The other factors that I think about for patients that have a medical condition in which they are considering fertility preservation is the safety of the medications with their underlying medical condition. We want to make sure that the medications that we're using for women who to stimulate their ovaries are considered safe with other medical conditions that they have, also other medications that they're on, and some of the medications that they require for their underlying medical condition may not be safe to take in parallel with the fertility drugs that we use. So that's a second factor that we consider. And then third, what is the timeline? So a professional woman, may not have a specific timeline outside of the ticking biological clock, but for a patient that has a medical condition, if there's some urgency on starting certain medications, and we might have a certain opportunity or window of time where patients are having to make very quick decisions because they know that they need to embark on their medical therapy, and so they may not have months or weeks to think about pursuing fertility preservation. So a lot of times for patients with a medical condition, the process goes very, very rapidly. So we do consultations, we counsel patients, we do some basic fertility testings, they have a follow-up appointment, and then we accelerate the process to get something like their eggs frozen in a timely fashion so that they can move on with their medical treatment. So I agree with you. The considerations that I have for a medical population is very different than a patient who may just want to do this because she wishes to postpone pregnancy.
Right. Yeah, I mean, I think that's so relevant, especially, in our population. Clinical trials come up with investigational drugs, which for one, we don't know, since they're investigational, we don't know the effects on reproduction. But I think more important is just that, if a woman is, let's say, at that critical age where you say in their late 20s, early 30s, maybe even mid 30s, and they're eligible for a clinical trial, and that investigational drug could mitigate, disease, and there's a hold on family planning, let's say for 4 to 6 years. I mean, that could shift, their reproductive window, and so in that case, that could be a reason why they might want to have a fertility consultation to see where they are and if egg freezing might be something that would be an interest to them.
I agree with you. And when I have patients that are on these medications for an extended period of time, a lot of times that medication is given in our prime reproductive years. And so that prevents women from that opportunity of maybe starting a family. And this, by going through a process like egg freezing, will allow them to maybe preserve eggs. And those eggs don't necessarily have to be used, because there are times that patients go through the process of egg freezing. They may be able to conceive naturally, but if they wanted to expand their family, they're just getting a little bit older, and that would be a great opportunity to use the frozen gametes when they're at a much younger age. So when I have women who are consulting with me for possible egg freezing, I tell them this does not preclude your ability per se for trying to have a natural conception, but this would be a great option if you're struggling with infertility, or you are wanting to expand your family and now you're in your late 30s or early 40s where natural pregnancy just be
just a little bit more difficult.
It does become more difficult. And I want to highlight how age has an impact on women, because I think that this will be really important for your audience. If we take women, let's say, for example, I had a woman who's 30 years old, and her possibility or ability to get pregnant naturally at age 30 is about 15% per month. That same woman, if she waited until she was 35, that drops to 10%. If she waits until she's 40 years old, the probability of natural pregnancy per month at age 40 is less than 5%. So you can see within that 1 decade that it really makes a difference. So if we have women who are on medications for 4 to 6 years and they're in their 30s, that is going to take up most of their, natural sort of reproductive years. There, and it just becomes more challenging as they get older when they stop the medications.
So let's say, there's a woman and she's thinking about, okay, maybe I am interested in pursuing this. Can we maybe just before we go into egg freezing, let's just talk about sperm freezing really quickly. Can you just explain what's involved in that? And then we can talk about egg freezing.
Absolutely. I think starting with sperm freezing is a great thing, because it's much simpler for men to go through gamete cryopreservation or fertility preservation. The mainstay of male fertility preservation is sperm cryopreservation, which just means freezing. That process, and this is appropriate for men that have gone through puberty. So this would not be appropriate for adolescent boys that have not gone through puberty. But for young adults and young men, what that entails is that men come in and essentially produce a sperm sample, and that sperm is going to be evaluated by our andrologists. Those are the specialists in our practice that specialize on the sperm side. And basically, when we freeze sperm, we eliminate all of the fluid. So the ejaculate has 2 parts. It has the sperm that's being produced in the testicle, and the fluid is coming from the prostate gland. So you can actually separate the fluid and get pure sperm. And essentially, when we freeze sperm, we only want the fastest swimming, the healthiest sperm. So we can place the sperm almost like a collision course. And so we put it through almost like a cylinder, and the fastest sperm is at the bottom, and then that sperm can be frozen. The technique that we use for either freezing sperm or eggs is called vitrification. It's essentially flash freezing. And so the sperm can be placed into a little vial. That vial can be frozen, and then sperm can be frozen for years to decades. There is no shelf life on frozen sperm. Usually when we freeze sperm, if a man produces a sample, we do separate the sperm into multiple small vials. So it is possible that you don't have to use all the frozen sperm for a single pregnancy. If we're able to separate it into multiple vials, it is possible that 1 vial of sperm may be appropriate for achieving a pregnancy. The 2 options for using cryopreserved sperm, it doesn't have to necessarily be in vitro fertilization. There is another option called intrauterine insemination, or the acronym is known as IUI. Sometimes folks will hear about it as being artificial insemination. That does not necessarily require any fertility treatment. A male who has frozen his sperm, if the sperm meets certain criteria, that could be used for IUI. And the female partner can use fertility medications or check for ovulation. When the time in the month is correct, the sperm can be thawed, placed into a little straw. We place it through the cervix into the uterus, and we can allow natural fertilization to happen in the fallopian tube. So with frozen sperm, we don't always have to go straight to IVF. IUI might be a good option. Alternatively, the other option would be in vitro fertilization or IVF. That's fertilizing eggs outside the body. So we can thaw the sperm, we can fertilize eggs, allow the embryo to grow, essentially in a petri dish, and then the embryo can be transferred into the uterus for a pregnancy. The sperm banking is usually only requires 1 appointment for a man to produce the sample. The sperm can be frozen, and then there's opportunities for future pregnancy using that frozen sperm.
Okay, and is there? I mean, I know I get this question a lot. Does freezing in any way harm the sperm or the egg in that process?
It doesn't, no. So we don't see that the freezing technique alters sort of the health or the quality of the sperm. One thing we do know that is that not all sperm that freezes will be viable when we go to thaw. The usual recovery rate is usually about 50%. So you will lose some of the sperm in the freezing and thawing, but that's just natural. natural. That would happen even if you let sperm, men collected a sperm sample and we allowed the sperm to kind of sit in the lab. After a couple of hours, the sperm is going to stop moving and not be viable anyway. So that's just the way sperm acts. But in terms of harming the sperm in the freezing and thawing, we don't see that.
Okay. All right. Thank you. All right. So then let's move on to egg freezing. Now, I know that there's a lot of different protocols among different fertility clinics. So can you just maybe walk us through the basics of what, someone can expect during, what that actually involves?
Absolutely. So the process for women that go through an egg freezing cycle, the treatment cycle has two components. It has something called priming and then the actual fertility medications. In the ovary for a woman at any given time, she has eggs that are essentially in the pipeline at different developmental stages. So for example, a woman, today is January 26th. In a woman's ovary, she would have the eggs that were sort of selected for January's menstrual cycle, but February, March, and April are already in the pipeline. So when women take the first part of the treatment, which is called priming, the goal of that medication is meant to keep all the eggs in a particular month, all in this holding pattern or synchronized, so that when you start the treatment or the fertility drugs, all of a woman's eggs are growing at the right pace. The fertility medications come in the form of injections. So these are subcutaneous shots that women take themselves. So we do teach patients how to give themselves the injections. Subcutaneous injections means you just have to pinch your skin and put the needle right underneath. The needles are teeny tiny. It's always a little intimidating, maybe the first or second day. I always tell women, take a deep breath, but you can do this. The injections go into the skin of your abdomen, and women take the medicines usually for about 10 to 11 days. Once women start the injections, we do ultrasound monitoring and blood work to see how she's responding to the fertility medicines. The ultrasounds are a vaginal ultrasound. That allows us to see how the ovaries are responding. And eggs are microscopic, so we can't actually see them with the human eye, but eggs are in our ovaries in little structures known as follicles. And the follicles essentially look like bubbles. And so on ultrasound, we can measure how big those follicles or bubbles are getting, and it's providing information about the microscopic egg inside. We also do blood work on a frequent basis. That allows us to see how a woman is responding, and we can make adjustments to her dosing as we go along. So once women start the injections, we do have frequent appointments. So for example, seeing us for blood work and ultrasound pretty much every other day.
Okay.
Once the follicles are the appropriate size, women take one last medication. Colloquially, it's known as the trigger shot. It causes the eggs to mature. And then a certain amount of time, usually in our practice, it's about 35 hours later, we can do a procedure called an egg retrieval.
Okay.
That is surgery. That does not require any incisions. There's no stitches, no scar tissue. Women will get anesthesia.
Okay.
The anesthesia is just IV sedation. So all the IV, and it's like sleeping medicine. So it's not considered general anesthesia where women have to have a breathing tube and connected to a respirator. Women will be breathing on their own. They'll be comfortable. They won't feel the procedure. They won't remember the procedure. And the surgery usually only takes about 10 or 15 minutes. It's a pretty quick procedure.
Okay.
And we just use vaginal ultrasound and a small needle to go through the top of the vagina. We can collect the eggs from the ovary. My embryologist will look through the fluid that we collect, identify the eggs, and there's a characteristic appearance of a mature egg, and those are the eggs that we freeze there.
Okay.
And most women are able to go back to work the following day after the egg retrieval. It is an outpatient surgery, and it only takes at most 15 minutes. And once the embryologists look at the eggs under a microscope, the eggs that are mature can be flash frozen, called vitrification. Basically, we place the eggs into a little straw. That straw is plunged into liquid nitrogen, and then we can freeze the eggs for years to decades. Eggs can, there again, with eggs, we don't see that the eggs degrade over time the longer they've been frozen. And in our facility, so CCRM Colorado was actually one of the first IVF clinics in the world to successfully freeze and thaw eggs. We've been doing it since 2007. Most other fertility clinics started in 2012. So that's one thing to keep in mind, for your audience, if you're thinking about doing this, be mindful about where you select to do your treatment makes a big difference on your overall success. The viability of frozen eggs in our practice is about 95%. That would be true if we thawed the eggs a year from now or 10 years from now. So eggs don't decline as they are in the freezer. But that kind of gives you a big overview of what the process would be for a woman. The protocol that you mentioned is actually the recipe, and we can tailor the recipe specific to a patient. That recipe includes the priming and the injections.
And I just also think it's important to talk about like the average number of cycles, that a woman needs to get a good amount of eggs, and if there ever is a good amount of eggs, because some women may expect just going through one round would give them enough, and for others, it takes a couple. So maybe you could expand on that a little bit.
Absolutely. So the best way for me to counsel women is by doing some basic fertility assessment or testing for ovarian reserve. Ovarian reserve is what's the pool of eggs a woman has at any point in her lifetime. And the way that we can assess that is with blood work, which is hormone testing, and ultrasound. And with that basic testing, which is always timed with a menstrual cycle, so it's usually done on the second or third day of a period. And for your audience members, if they're thinking about going through this process, we do have patients, if they're on birth control pills or any type of hormones, we do have them stop it to get accurate information when we do the basic ovarian reserve testing. And then we can do blood work and ultrasound. That will give me an assessment of how many eggs I'm expecting to retrieve from a single cycle or single surgery. That's important information because that helps me counsel a woman, hey, I think we're going to get enough eggs from a single surgery, or should you be prepared to do multiple retrievals? Now, a lot of times women will ask me, how many eggs do I need to have frozen? And I go back and say, well, how many children ideally would you like to have in the future? What the data shows is that for women who are under the age of 35, having 8 to 10 mature eggs frozen is what we would recommend for one baby in the future. There is a lot of attrition that happens when women come back to use their frozen eggs. And, different from men who freeze their sperm, men can use that sperm for either IUI or IVF. A woman who wants to use her frozen eggs, the only option would be in vitro fertilization or IVF. We would take the eggs out of the freezer, we can fertilize with the sperm source, we can let the embryo grow in the petri dish, and then that embryo can be transferred back into the uterus for pregnancy. So there wouldn't be other options there. So a woman under 35, 8 to 10 eggs for one baby. If she wants to have enough eggs for 2 children, I tell her, she needs about 20 eggs. If a woman is 35 to 37, she needs about 12 eggs for one baby. So in order to have enough eggs for 2 children, she needs to have closer to 25. And the older a woman is, the more eggs she needs to have frozen for the family size that she requires or she desires in the future.
Okay. Yeah, I mean, just following up on that, although age is kind of something that's out of our control when it comes to preserving fertility, prior to let's say an upcoming clinical trial,
Yes.
What would you say is the ideal age or like age range for a female to undergo egg freezing to maximize, as you said, your egg quantity diminishes over time, your egg quality does, and just
Yeah.
overall excess?
Yes. So ideal candidates for egg freezing are women who are under the age of 35.
Okay.
Now, certainly we will do egg freezing for women in their mid to late 30s, even their early or mid 40s. But again, what happens is that as women age, they will need to undergo more cycles of egg freezing to have healthy embryos in the future. So the ideal candidates are going to be women under the age of 35 or even under the age of 30.
Okay. And then what is the typical success rate of using frozen eggs ending up with a live birth? I know you talked about this, but when individuals with genetic diseases such as early onset familial Alzheimer's disease use their frozen eggs to create embryos, they might consider doing PGT or genetic screening for a mutation and only keep the embryos that are negative. So how would that affect their success rate, going into that as well?
Well, I think the success rates or chances of being successful using frozen eggs, again, will go back to age.
Okay.
Because as women get older, their eggs and their embryos will be prone to more genetic issues. And so in general, in our practice, our viability of frozen eggs in our hands, eggs that we have frozen and thawed, is about 90 to 95% will be viable, and we can have them for fertilization. Now, to get from the egg to an embryo, there's a tremendous amount of attrition. There's various factors that are associated with that. For example, a woman may go through the process of freezing her eggs when she is young, let's say 28 or 30 years old. However, later in life, she has a partner that may have a male fertility issue. And so the sperm may not be as healthy, so we don't get as many embryos as we expect, even though she went through the process when she was young and healthy at age 28. So there's some other factors that are associated with sort of success and having a pregnancy outcome that's desired. If a patient is interested in genetic screening of the embryos, we also consider, is this an autosomal recessive illness or autosomal dominant illness? Because that will determine the proportion of embryos that would be affected versus unaffected. And if in the case of an autosomal dominant genetic mutation, we would expect about 50% of the embryos to be affected. And so if you think about losing half of the embryos on the genetic screening, then you can imagine you need to have a lot more eggs to start with to be able to overcome all of the speed bumps to get to an embryo. And then at the embryo stage, now we have another speed bump to overcome, which would be the genetic testing. So it's all dependent on a specific patient's profile.
I think you touched on really two important points, and I'm jumping ahead a little bit, but if somebody does have a partner, would you then recommend freezing the embryo over freezing an egg?
I think it depends on age, because for women who are under the age of 35, what the data shows is that overall pregnancy rates in the future are very similar if that woman decided to freeze her eggs now or went ahead and made embryos. So I think age would be a consideration that we would have. The other thing that I think about and what I do advise patients is that once women decide to go through this process and fertility preservation and we fertilize the eggs and create embryos, we cannot go back in time. We cannot unfertilize those eggs. And over time, there can be changes in relationship status. There can be different factors that can come up for a couple, even in the course of their relationship. And if we've already created embryos and now she's a little bit older, we can't go back in case that relationship does not continue, and she might have a new partner and she wants to have start a family with a different partner. So freezing eggs is a great option because it gives women a lot of flexibility about selecting the sperm source for the future. And for women under the age of 35, their overall pregnancy rate is unchanged if they created embryos right away versus creating freezing eggs by themselves.
Okay. Interesting. I didn't expect that. But, and then the other important point that you touched on was, the genetic testing. And I know I'm jumping a little bit ahead, but I think it's relevant to what we're talking about now, because I get this question a lot. Can you test an egg for a mutation?
Great.
Or do you have to wait until it's an embryo?
You do. So you do have to wait until an egg is fertilized and we create an embryo. So even if a female partner has the gene mutation, we can't just test the egg. When we do genetic testing of embryos, we actually biopsy or remove a couple of cells from the surface of the embryo, and then we can extract the DNA and then screen for a specific gene mutation. You can also do chromosome testing as well. So there's a variety of different types of genetic analysis that can be done. If we were to extract the DNA out of an egg, there's no DNA that's available in that egg to fertilize and create an embryo. So that's one consideration. The second thing is that when the egg and sperm meet at the time of fertilization, there's so much genetic shuffling that occurs. It's called recombination. And that always happens at the time of fertilization. And then the embryo is inheriting certain types of genetic material. And so you would only get half the information if you were only to screen the egg or the sperm. And because of that genetic shuffling, the best opportunity based on the technology as it is right now is to screen the embryo. So unfortunately, you can't just do genetic screening on the egg or the sperm. We do have to create the embryo and then do genetic testing on the embryo.
Right. Because isn't it that in the gametes, right, you only really have one chromosome, and to create an embryo, you have two chromosomes, and you get each one from each parent, and you never know, which one would actually end up for the gene that may have the mutation, right? So there's no way of knowing. That's where chances come up in having a baby, and whether a baby's at risk of a disease is that shuffling that you said. Mm-hmm.
Yeah, exactly.
Okay, so I think it's also important, one of the biggest burdens, I think, to egg freezing is costs. And I know that this can vary by state and clinic. What are the typical costs, of egg freezing that an individual can expect to maybe start saving for, or, at least looking into? Does health insurance cover it usually? Yeah. Or
this is one of the areas that's so variable from state to state, from insurance company to insurance company. So I wish I could give you an estimate of about a typical cost, but it is so widely variable. It could be a few $1,000s to $15,000,
okay.
Depending on where a person seeks care. A couple of things to keep in mind is that there are certain states across the country that have mandates for fertility treatment, and some states will also have insurance coverage for fertility preservation. So thinking about what state you live in and seeing if it's one of the mandated states for insurance coverages, and then going a step further and seeing if fertility preservation is also included in that state law. In the state of Colorado, there was a bill that was sponsored last year, and I'm really pleased to say that it was approved and passed by the governor in Colorado. So Colorado proudly is the 18th state in the US that has a mandate for insurance coverage for fertility treatments, including fertility preservation. So checking with your state will be helpful. Secondly is checking with your insurance. There are certain types of insurance that you may have through your employer that has infertility or fertility coverage, and fertility preservation could be included in that. Also checking with your human resources department to see if open enrollment is available, are there certain opportunities to have additional insurance that would include fertility coverage. And some employers will actually have certain types of insurance that is in addition to your health insurance that's specific to fertility treatments, and egg freezing would be included in that. So those are the sort of opportunities or resources that a person may have. Now, I have had patients where we have written a letter of medical necessity if they have a medical condition or something that predisposes them to infertility. So, talking to a fertility specialist like myself, they can be your advocate, and sometimes they can approach the insurance company and make an argument as to why egg freezing or sperm freezing or fertility preservation would be indicated for a person.
And what is the typical cost of a fertility consultation? Like, what can you usually expect to pay?
Yeah, so again, I think that will depend on who you seek treatment from and who you want to see a consult for. So that could be, that's going to be specific to the practice that you go to.
Okay.
In our practice, a typical new patient consultation, and many times patients have coverage for it. So they may not even have an out-of-pocket cost for the actual consultation, but a typical consultation is around $300 or $350.
Okay. Yeah, that's a good just price range to kind of know. We're in the hundreds versus the thousands.
Yes.
So another thing I want to touch on, is I've heard it a lot, is that there are these physical and emotional burdens that women face when they go through egg freezing. And I'm just curious if you would agree with this. I mean, what do you think women should expect or prepare themselves for when they're facing these potential barriers, and what might help them better overcome these barriers per se?
Sure. The common side effects of the fertility medications are going to be bloating. So a third of women do feel bloated because their ovaries are getting enlarged and they feel pelvic fullness. Also, because their hormone levels are going up, they may feel a little bit of extra water weight. So it's very, very common for women to gain anywhere from 3 to 5 pounds during that 2-week period of time when they're on the fertility medications. And a lot of that is just extra water weight because of the hormones. That could mean puffiness in their hands, puffiness in their ankles. Sometimes women can spill a little bit of fluid into their lungs and feel short of breath. All of this is self-resolving, and oftentimes after we do the egg harvesting, a woman will get a normal menstrual cycle within 10 to 12 days. And by that time, she will have excreted all that extra or excess water and feel back to normal. So bloating is the most common side effect. Pain at the injection site, because women are having to administer these medications in their abdomen. I do have women who say, gosh, I start feeling like a pincushion because I'm giving myself these shots, pretty frequently. I don't hear from a lot of women that emotional lability or symptoms from the hormones has really affected them too much. There are some other medications that we give women during the injections, and sometimes they can have some insomnia or trouble sleeping from those medications. But I have more women who tell me that they were expecting that the side effects would be much worse than they actually experienced. Some of the ways or strategies to kind of deal with some of the side effects, one could be, if you have a friend or someone who's gone through the process, talking to them, because having that personal experience or hearing from other folks and kind of what they went through can be really, really helpful to alleviate some of the myths or the concerns about what the medications are like. And then 2, your clinical team is also a great resource. So for example, in our practice, when I have a woman who's already consulted with me, we've done the initial ovarian reserve testing, I have a follow-up, and now we've made the decision that she wants to move forward. She meets with one of my nurses, and my nurses do a very extensive consultation that kind of gives them a much more detailed nuts and bolts information about what the process looks like, what to expect, how to deal with some of the side effects, making sure they can take the medications themselves. So we teach women how to do the shots, and that is a pretty extensive consultation with the nurse to go through all the specifics of the process. One other thing to keep in mind is once women start the medications, the injections part of the treatment process, we do have activity restrictions. So if a woman typically uses running or cycling or yoga or some other physical activity as a great way for stress relief, for managing symptoms, unfortunately, that would not be permitted once women start the shots. So we do limit activity to just walks, maybe even light hiking, but nothing more vigorous. The ovaries get bigger and bigger, and there is a rare complication known as torsion, where with any type of twisting motion of your torso, the ovary can actually swing and twist on its blood supply. That is an emergency known as torsion, and that requires emergency surgery. So we do have women, once they go start the injections until they get their period, to limit exercise to just walk. So exercise might be a great coping mechanism. Unfortunately for this process, it's not one of the strategies outside of extended long walks.
Yeah. But again, like those side effects, that bloating, that's really just during the injections, which is a 2-week period.
That's right. And sometimes women can have a little bit of bloating even after the egg retrieval, but by the time they get back to their period, they feel, pretty much back to normal. So it's a short period of time of having some of these side effects.
Yeah. And I love the idea of creating kind of a support network while you're going through this, because at least in Youngtimers, we have a lot of support groups going on, and it just makes that big of a difference, when you're facing what feels like a very difficult thing. It just makes it that much easier. So
it is.
I love that idea. So you actually already kind of talked about what the risks are associated to egg freezing. Is there anything you wanted to add other than, the bloating and like that torsion that could happen if you are maybe engaged in strenuous activity?
Yeah, and those risks are very, very rare. Torsion is exceedingly rare. The bloating is pretty common. There's a rare complication known as ovarian hyperstimulation syndrome, or OHSS. That's where women's estrogen levels get very high. They become puffy all over. They can feel short of breath because they have fluid in their lungs. Even with that, it is self-resolving, and the treatment is actually drinking more liquids, and eventually the kidneys will kick in and women will absorb all of that liquid and excrete it in their urine. But that's a pretty rare complication that occurs. The risks of the surgical procedure are rare. We use a needle through the top of the vagina, so there is a chance of bleeding. There is a chance of an infection developing from the procedure, but we give women prophylactic antibiotics to reduce that risk. There is a risk of injuring maybe the bowel or the bladder, but we do these procedures with ultrasound guidance, so we see exactly where the needle is going, and the likelihood of a complication is very, very minimal from these types of surgeries.
Okay. We talked a little bit on the advantages and disadvantage of freezing eggs versus freezing embryos. And did you want to expand on that at all? Are there cases where you would recommend freezing embryos over freezing eggs and sperm, specifically in a disease, community? Or do you have any thoughts?
Sure.
Any more thoughts on that?
Absolutely. So the biggest difference between freezing eggs and embryos is the viability on the thaw. So in our practice, about 95% of eggs will be viable in the future when we're ready to use them, versus in our hands, about 98 to 99% of embryos will be viable. And it's because an embryo is just a more robust structure. An egg has one single cell, so we're hoping that one cell will survive that freezing and thawing process versus an embryo, which has close to 100 cells. It's a much more robust group of cells, and so that's why the survival rate is higher. One of the advantages of creating embryos is that if we have a patient that is partnered, is committed to going ahead and fertilizing her eggs, and is interested in that genetic screening of the embryos, all of that can happen even before we freeze the embryo. So, for example, if there's a specific gene mutation that a couple is interested in screening their embryos for, we can go through the process. The process of the hormonal stimulation, the egg retrieval is exactly the same if a woman chooses to freeze her eggs or create embryos. So for the female partner, the process is the same. It's just what happens in the IVF lab. If we're creating embryos, we'll go ahead and fertilize the embryos right at the time of the egg retrieval. We will let the embryo grow in the IVF lab for 5 or 6 days. The embryo can be biopsied, which means we remove a couple of cells from the surface of the embryo, and then the embryo is frozen. And so then we can do the genetic testing. The advantage of creating the embryos, and in that example, going ahead and doing the genetic testing, is that a patient or a couple has a realistic idea of how many healthy embryos do I have when I'm ready to start a family. And if that number of healthy embryos does not feel comfortable for a patient, they can choose to go through another retrieval, maybe make more embryos so they have them available for the future. One of the disadvantages of freezing eggs, and many times I tell women this, is I don't know how good your eggs are or what the performance of your eggs are until the future when you're ready to fertilize them. We create embryos, and then we know how many embryos we're having. Even though I expect, for a woman who is under 35 that she needs about 20 eggs for 2 kids in the future, it's possible that she has some underlying egg quality issue, and maybe her eggs are aging beyond her chronologic age. And in the future, when she comes back, we don't get that many embryos. And now she's much older and thinking about going through the process at age 40, we're not getting as healthy eggs as when we were 32 years old or so. So those are some of the considerations that we have when we're talking to patients. Does it make sense to freeze eggs? Does it make sense to freeze embryos? Because for women who freeze eggs, we really don't have a good assessment about the performance or how many embryos we'll have until she's ready to fertilize and create the embryos.
Yeah, those are such great points. And I just wanted to say, I know we'll be talking about, that embryo process, including the genetic screening at a later point. But I just want to mention that, a lot of this population is, interested or not interested. They're very passionate about either one, about pursuing genetic testing. And some of them really want to know their status, and some of them really don't want to know their status.
Yes.
And I think it's important to note that you can screen your embryos without actually ever learning your status.
That is correct. And that is something known as non-disclosure. So sometimes we have patients that are interested in going through this process, but not actually knowing sort of the genetic test results. So we're pretty flexible in terms of disclosure to a patient, in terms of how much information they will want versus how much they don't want. Now, one thing to keep in mind, if I have a patient that is interested in genetic screening of their embryos, let's say for a specific gene mutation, we do need to have a molecular report as to what that gene looks like, because when we do that screening on an embryo, we essentially create a molecular tag. And that allows me to screen that embryo. Now, we're not doing routine screening of 25,000 genes, which is what the human body is made of. So we're not doing global screening on embryos, but if I know that there's a specific mutation, then I can screen for that in embryo. Now, if a patient doesn't want to know what their status is, they could potentially get that testing. That testing results could be sent to my office. If it is positive, then we can go through that process of doing the molecular tag.
Right. Mm-hmm.
Yeah.
Yeah, but if they had, for example, their parents report,
Yeah.
or their grandparents report, then that would also work for your lab.
It would be, and many times when we create these molecular tags, we do want to have other family members that have that gene mutation. It helps us create that tag, and it increases the accuracy of that probe.
All right. Well, this has been such a great discussion. I just want to ask one last question. And I know we already touched on this, but I think that it's probably the most important and critical question that's kind of facing our community is if somebody is worried about losing their prime fertile years due to either treatment or study participation and is interested in egg freezing, what steps would you recommend they take to make an informed decision?
Absolutely. I think getting the information and seeking a fertility consultation from a reproductive endocrinologist or infertility specialist would be a key first step. And if you can identify a specialist that also has expertise in fertility preservation, specifically in a medical population, is what I would recommend. Even though I live in Colorado, about half of my patients don't live in the state of Colorado or don't even live in the United States. So a lot of times I see patients that are from other states that come to seek care with me in Colorado. And I do see a lot of fertility preservation patients for medical issues, cancers, variety of different things that choose to do treatment with us. So certainly seeking a fertility consultation is step one. That consultation, what that would look like is that we go through extensive past medical history, kind of get a sense of their gynecologic history, all of that, their family history, and then if a patient wishes to move forward with an evaluation, we would be scheduling hormone testing, the ultrasound. For men, it's just a matter of coming in for a sperm collection and doing sperm freezing. If I have patients that don't live in Colorado, and in fact, even if I have patients that live in Colorado, all of our appointments are virtual. So we just do a virtual visit. I review all of the medical history. We come up with a plan for what the testing would look like. For a person who doesn't live in Colorado, they actually come to see me in Denver for something known as a one-day workup, where we can do almost all of the testing in a single visit. They meet with my nurses. It's a very efficient use of their time because everything is done in one day. We can start to come up with a treatment plan. They go back home. We have a follow-up telehealth visit, and then they can move forward with treatment. But I think step one is getting a fertility consultation. And that way you can have a tailored evaluation about your medical history.
Mm-hmm.
We can talk through a little bit more specifics about what the next steps are, and a little bit more information and counseling about if this is a good option for a particular person.
And just as one last follow-up, I know a lot of patients are, very scared about genetic discrimination. And so they want to be very cautious when they let medical professionals know about the risk of their, inheritance of a disease. So is there a way to talk to a reproductive endocrinologist about those concerns without that necessarily going into their medical record?
Absolutely. For sure. So sometimes patients have those same kinds of concerns. So that could be something that is discussed at that initial consultation. And so that we can maintain some privacy or to the level of comfort that a person has. Absolutely.
All right. Well, thank you again so much for all of your insight and expertise on gamete cryopreservation. We really appreciate you taking the time away from your patients and to just answer a lot of our questions and concerns regarding this very new field. We're normally in neurology, which is all about the brain.
That's
We
right.
don't go south of the shoulders very much. So it was really a pleasure talking to you. And thank you so much for taking the time and giving such great answers and guidance.
Lindsay, thank you so much for inviting me to participate today. I really enjoyed our discussion. I think that this is such an important topic, especially for young folks that are kind of thinking about, family planning for the future. So I'm really pleased to participate in today's visit.